Yes, it is moving forward, and I apologize. I didn't tell you I was going to record, but I am recording. So,
Perfect. That's great. Wonderful. We'll walk through some objectives today. We're going to go through some of the common types of rock climbing injuries that expect the upper extremity. We'll start at the shoulder and move down to the elbow and the hand. We're going to discuss rock climbing handholds and how they specifically tend to cause or predispose climbers to some unique types of injuries that we don't tend to see in other clinical scenarios. And then we're going to discuss some appropriate management techniques that you guys can utilize in your practice if you're seeing these patients when they come in complaining of these injuries. So again, we'll walk from the shoulder down to the hand. So a little bit of epidemiology. Who the heck is rock climbing these days? Well, the answer is a lot more people than there used to be. In 2017, 7.1 million people were estimated to participate in that, and that number is only increasing. I was really surprised that 53 new gyms opened in a study I had looked at in 2021, despite the COVID pandemic. Most of these are indoor gyms, and certainly a lot more people are getting engaged in the outdoor recreation side of things as well. And this growth is only expected to continue now that recently rock climbing has been added into the Tokyo Olympics in 2020. So certainly no anatomic location is spared with rock climbing. Certainly the lower extremity and the torso and the head are all involved as well, but figured we had to keep this presentation to an hour. So we're going to focus on the upper extremity where some of the more common injuries take place. But if you look at these by the numbers, they're actually pretty evenly split between chronic, acute atraumatic, and traumatic injuries, roughly about a third in each of these categories. So starting with the shoulder, about 17% of all climbing injuries are related to the shoulder itself, and 40% of all upper extremity climbing injuries are related to the shoulder. The most common two that I think you'll see in your practice are from subacromial impingement and also from labral tearing. So first, to review a little anatomy here, you've got multiple bones that are in the peripheral skeleton that connect to the axial skeleton. So the collarbone is the only bone that truly connects the upper extremity to the torso. It articulates with the acromion, which is the pointy portion of the shoulder blade that reaches around and forms the AC joint. And then down below that, you've got the head of the humerus that articulates with the glenoid to give you the glenohumeral joint. Now for a little bit of muscular review, we're all familiar with the sits muscles of the rotator cuff, and those are extremely important muscles when you're considering rock climbing. These are the main muscles that allow for internal rotation, external rotation, and abduction of the shoulder. So very important muscles and easily injured muscles, as we'll see here in a few minutes. And then you've got a few bigger muscle groups over the top. Mainly involved in rock climbing would be the trapezius, your deltoid that overlies the top of the shoulder, pectoralis in the front of the shoulder, your latissimus in the back of the shoulder, and your biceps as well. So these pictures represent why rock climbing is basically a horrible sport when you're discussing shoulder injuries. The perfect setup to injure your rotator cuff or your labrum is to be doing any kind of activity in a hyperabduction, hyper-forward flexion state, which is basically all of rock climbing, where you're climbing with your shoulders up above your head the majority of the time. That really sets people up for our first topic here, which is subacromial impingement. And this can present as pain in a few different ways. On this picture on the right, there's a blue bursa sac. And certainly you can get true bursitis, which is inflammation within that bursa itself. Also, this tends to present concomitantly with tendinitis or tendinosis of the rotator cuff. This can be brought on by multiple different problems. One is you can have an acute injury where you fall and twist your arm in such a way that you drive the greater tuberosity of the humerus up into the bursa and the acromion pinching structures underneath it there. The other that is a little bit represented by this picture on the left that I see with rock climbers is they tend to have extraordinarily strong deltoid muscles on the outside. And that can easily overpower a weaker rotator cuff, driving the humeral head superiorly into the tendons. The best way I've thought to think about this when discussing it with patients is it's a little bit like biting your lip. Your lip lives in your mouth all the time, and it's not a problem until you bite your lip. And then your lip gets a little fat and swollen, and you keep biting your lip in the same place, and it's a vicious cycle. The same thing happens in the shoulder. You get an acute injury, there's narrowing of the space and a fat inflamed tendon, and the cycle perpetuates itself. So treatment exercises that I think is hard to stress, that really needs to be stressed in our young athletic population, is either home exercises or physical therapy. Patients will argue with you that they can rock climb to the nth degree and they're going up half dome and they're really strong. They don't need exercises. The problem is those exercises are all targeting large major muscle groups and not the rotator cuff itself. So if you can help them realize that they need to do a different, much less romantic seeming exercise to target their rotator cuff, they'll have good improvement with their symptoms. And if those don't work, you can certainly go on down the list to steroid injection, anti-inflammatories, and surgery. Let's see, here we go. Moving on to labral tears. So the labrum is a soft tissue ring that lives around the rim of the glenoid. You can tear this in a few different ways. This large tearing seen in this picture here would more likely be seen with a traumatic dislocation, for example. The more common thing that we would likely see from a routine overhead athlete is a slap tear, and that stands for superior labrum anterior to posterior. This is a tear of the labrum right at the attachment where the long head of the biceps tendon inserts at the anterior superior aspect of the glenoid. That tends to be what you'll see from your rock climbers and you'll find on your MRI. For these, another similar story where I always start out with physical therapy. A lot of patients live their lives with labral tears and they don't hurt. So just having a labral tear is not an indication for surgery. If you can strengthen up the rotator cuff and the muscles around the labrum and basically compensate for the labrum, then you can avoid injections and surgery altogether. But certainly if therapy is not working in and of itself, an intra-articular glenohumeral joint injection or surgery could certainly be considered. Moving on down to the elbow, this is about 9% of upper extremity rock climbing injuries. We'll talk about a few that I'm sure you guys are all familiar with, the tennis elbow and golfer's elbow, and then a different one that at least in the climbing literature is referred to as climber's elbow. So here's pictures of our classic lateral and medial epicondylitis. They're a problem where for tennis elbow, all of the extensor muscles on the dorsal forearm attach at the lateral epicondyle, and all the flexor musculature on the volar aspect of the forearm attaches at the medial epicondyle. And I think what we often overlook is that this initially starts out as a tendonitis, absolutely. But quite often, by the time this shows up in your clinic, people have had it for a long time and it's now tendinosis. And what the heck is tendinosis and why do we care and why is it named differently? Why it's important is a lot of our tendonitis treatment options don't work so well for tendinosis. Tendinitis is an acute inflammatory process where you've got an inflammation, a lot of inflammatory mediators floating around. If those are present for long periods of time, all of those inflammatory factors and cytokines stimulate your collagen fibers and your tendon to try to heal itself. And it does that by laying down new collagen. But rather than doing it in a nice, orderly fashion the way it should, it lays down disorganized collagen. And all of these inflammatory mediators stimulate more protein synthesis and new blood vessel formation. But we find that these blood vessels are poorly formed and a little bit leaky. And so you end up with kind of a chronic schmutz problem that is what tendinosis is. So if you've got just tendinitis, a lot of time anti-inflammatories work well because it's an inflammatory problem. When it's degraded into a tendinosis problem, anti-inflammatories tend to be a lot less helpful because it's no longer an acute inflammation problem. The other issue is tendon is a relatively avascular structure, so oral anti-inflammatories have a hard time getting to these areas in high enough concentration to be therapeutic anyways. So there's a lot of treatments for both medial and lateral epicondylitis. Certainly counterforce bracing is a really helpful one. I find where people go wrong with it though is we tell people you can try this tennis elbow brace and see if it helps. And people say, well, gosh, my arm was hurting when I was sitting there and I put that brace on and it didn't help. This brace will likely only help with activities. The point of the brace is to change the fulcrum, the area where pressure is being applied into the muscle belly and offload your inflamed and irritated tendon. So just remind people that their tennis elbow brace would only work for pain for an activity like climbing, or if you've got one of the working population when they're doing their work. Physical therapy is one of my mainstays of treatment for these problems. And what we need to do to remodel that disordered collagen are what's called eccentric strengthening exercises. I'm a pretty simple guy. The easiest thing for me to think about that is a bicep curl. When you're lifting a barbell and doing a bicep curl, you're contracting your biceps and shortening the muscle to do the action. That's a concentric exercise. Eccentric is where you're lowering that weight back down. You're still contracting your biceps to control the weight, but you're lengthening that muscle as you're contracting it. That is maximum weight through your tendon and allows for remodeling of that disorganized collagen. That's where I find a lot of my patients who can't afford or don't have time to go to physical therapy benefit from this device called the TheraBand Flex Bar. I'm not sponsored by them. I should pitch that and see if they'll pay me money to put that in my future talks. It's this sort of foam bar that you can get in several different colors, which are different resistances. And you hold the bar out in front of you and rotate your hands forward and back. And that will create this eccentric pull on your extensor or your flexor muscles in the forearm to help target those exercises. And you can buy them online at Amazon. If those things don't work, topical or oral anti-inflammatories and steroid injection are certainly reasonable options, and surgery sometimes is ultimately required to address these problems. This is one I find people are a little less familiar with. This is called climber's elbow, at least again in climbing circles. And I tend to get people who say, I've got pain in my forearm near my elbow, and they kind of dig their finger underneath their biceps. And they've been told, oh, you just have biceps tendinitis, you're overusing your biceps, but they don't tend to hurt with our typical biceps tests. Well, going back to the good old days of anatomy, what lives right in that area underneath your biceps? You've got another big muscle called your brachialis muscle, and that's another flexor of the forearm. And climber's elbow is a brachialis tendinitis. And why would climbers exclusively be set up for a brachialis tendinitis? It has to do with rock climbing and the way that your arm is positioned during most climbing. Typically, when someone's climbing, their elbow is flexed at 90 degrees and their hand is completely pronated. The biceps is one of the main flexors and supinators of the hand. So in a completely pronated position, you aren't using your biceps at all. It's all brachialis that's being used to create that 90 degrees of flexion force. Moving on down to the hand, this is where over half of the upper extremity injuries come down into the hand. And I'm sure we could probably have come up with a whole hour presentation just talking about the hand itself. It's a quite complex structure. This again tends to be largely due to unique positioning of various hand holds and specialized anatomy, the way the hand and the fingers are made. So this is to review some common grips in rock climbing for those that aren't familiar. The first two, an A and B, are the open and closed crimp. And this is honestly what the majority of rock climbing is. And you can see that it puts all of your weight and a dramatic amount of pressure on both the distal interphalangeal joint of the fingers as well as the proximal interphalangeal joint of the fingers, and is basically all driven by the flexor tendons in the hand and the forearm. C is the pincher grip, and you can see that that would put a lot of stress against your thumb if you were pushing against that from a distance. And that over time can stress the ulnar collateral ligament of the thumb in the same way that skier's thumb or gamekeeper's thumb can. These, though, tend to be more a chronic attritional rupture of the UCL rather than an acute, I fell on it type injury. Letter D here is the sloper grip. I don't tend to see too many issues with that grip in particular. Letter E is the single finger pocket grip. We'll talk at length about this one. This is a really interesting grip that sets people up for a unique injury in the hand that I've never seen encountered in any other environment before. And it all has to deal with isolated extension of your third or fourth finger at the same time as flexing all of your other fingers. The two-finger pocket grip is better, but can still potentially set you up for some risky issues. I don't have any problems with G, other than I guess it could set you up for subacromial impingement. And then H is this undercling grip, where you're basically grabbing something below you and pulling up against that grip to hold yourself up while using an underhand grip. And that sets us up for another interesting issue in the wrist we'll cover here in a minute. So just another brief reminder, there's a lot of bony structures in the hand. You've got your phalanges, your metacarpals, and your 8 carpal bones. The hand has this very interesting muscular setup where you basically have 2 sets of muscles. You've got the intrinsic hand muscles that live inside the hand, and you've got these extrinsic muscles that live in the forearm and send these long tendinous bands into the hand and act almost as a marionette phenomenon where you're driving it from a long ways away, but you can get these issues distal to where the muscle itself attaches. So this is a front volar view of a hand here. So you can see the carpal tunnel and your flexor tendons coming underneath the carpal tunnel and extending into all of your fingers. Those are all extraordinarily important structures when it comes to that crimp and full crimp grip. The finger pulleys are extraordinarily important here. They're these ligamentous thickening structures that are basically present from your metacarpal heads distally to the tips of the fingers. You've got 5 annular pulleys and 4 cruciform pulleys. Annular pulleys are the big ones. If you injure your annular pulleys, you can get tendon functionality issues. We're all pretty familiar with stenosing tenosynovitis at the A1 pulley, that's trigger finger. That certainly happens with your average everyday rock climber as well, but that's one I think more people are familiar with. I think some of these isolated pulley ruptures are a little more uncommon in your everyday practice. And what tends to set people up for this type of injury is an eccentric loading of the tendon. Again, where you're contracting the muscle while the muscle is lengthening. And that tends to be when a climber is beginning a fall. They try to catch themselves and their body elongates that muscle, putting an extreme amount of force through those pulleys, resulting in pulley rupture. Here's an example of bowstringing. I know we've probably all heard and talked about that, but for a long time, I didn't really appreciate what bowstringing was. And so that's where the flexor tendons get pulled away from either the metacarpals or the phalanges, where they're supposed to be being held down by those pulleys. There's a grading system, not that you guys will never or need to know about this, but it's there in case you guys were ever interested. Most often you just get a pulley strain, and that's reproducible tenderness at the anatomic location of the pulley. Someone will say, I was climbing and I had a fall and now it hurts right at the base of my proximal phalanx, and that would likely be an A2 strain. You would notice bowstringing if you had complete ruptures of one or more of these pulleys, and the grade gets worse basically with the more pulleys you've ruptured. The difference between 2 and 3 tends to be which pulley you've ruptured, and that severity is just based on which pulleys you need for rock climbing grip strength. A2 and A3 being more necessary than A4, for example. So it wouldn't be a slideshow from a primary care sports medicine physician if I didn't put some kind of musculoskeletal ultrasound image up here. But this is just one really cool way that ultrasound can come into play that's a more helpful dynamic study than, say, an MRI. If you got an MRI of someone's hand, they may be able to clue you into that you have a pulley rupture by having a lot of edema around one of the pulleys. And they would probably say something like, could correlate to possible pulley rupture, please clinically correlate. There's a great article in the Journal of Environmental and Wilderness Medicine where they looked at a bunch of rock climbers and did measurements on what is a resting distance of FDS and FDP, flexor digitorum profundus and superficialis. How far away do they rest from the metacarpals and the phalanx? And what would be a pathologic distance? So you can find the tendon and then have the patient flex their finger against resistance. And if that tendon pulls away from the bone a certain distance, you've got a diagnostic criteria of pulley rupture. And then you can decide which pulley it is based on where the tendon is bowstringing. I'd have to go look it up. I think normal is something less than 2 millimeters of gapping between the flexor tendons and the metacarpal. And if you get to over 3 millimeters of gapping, that's diagnostic for pulley rupture. Treatment for these is actually pretty simple. People can do these on their own with some taping. And basically you recreate the pulley with some athletic tape. And where you position that tape is based on which pulley is injured. So this picture here would be replicating an A2 pulley injury. That's a pretty simple one. Some people tend to like this H taping better, even if they've only had an A2 pulley injury. They find this provides them more support. So these are the two most common. They do have prefabricated plastic sort of clips that you can clip on your finger for these, sort of like they do the prefabricated mallet finger splints. I just don't know where to get them. I'm assuming Amazon. Amazon's got everything. So if you are big into the climbing scene, you could maybe order some of those into your practice if you were seeing a lot of rock climbers. The recommendation for pulley injuries is typically tape it immediately and take a break from climbing so that the taping can give you rest of that pulley injury with just everyday gripping and grasping techniques. And then they just say a gradual return to climbing. There wasn't a real definitive take 2 to 4 weeks off of climbing. I think it's more as symptoms allow. When you're asymptomatic with everyday activities at home, then you would consider transitioning back into climbing. And for most injuries, they recommended at least 12 weeks. For those severe grade 4 injuries, they recommended taping with climbing for an entire year. So lumbrical injuries. This is a really interesting one for me because I don't think about lumbrical muscles too often. And what's so unique about lumbricals that's different? Well, once again, it all has to do with that darn anatomy. So these are intrinsic muscles deep in the hand that help you flex your metacarpal phalangeal joint to 90 degrees. And the two unique things about this muscle are, one, this is the only muscle I'm aware of that its origin is off of a tendon, not another muscle. The lumbrical originates off of FDP tendon and it inserts onto your proximal phalanx. So that's unique. Usually a muscle originates on a bone and inserts on a bone so you can flex a joint. This is originating on a tendon and inserting on a bone. The other unique thing about the lumbricals is the first and second lumbrical are a unipennate muscle. It only attaches and has fibers running in one direction, where lumbricals 3 and 4 are bipennate. They've got two muscle bellies coming from two different flexor tendons coming together to the same insertion point. So that leads us into lumbrical shift syndrome, which is an entity that's unique to rock climbing and that single finger pocket hold, where if you're extending one finger and holding your weight while flexing all of the others, if you're doing that with your third, fourth, or fifth finger, you're pulling that bipennate lumbrical in two different directions. Half of the muscle is being extended while the other half of the muscle is being flexed, and you can get this intrinsic musculotendinous junction tear or injury in the lumbrical itself. So here's an example. This gentleman's right arm, which is doing this single finger pocket hold, is significantly riskier for that lumbrical shift injury than the two finger pocket hold, where you're more likely to keep those two muscle bellies of the lumbrical going in the same direction. The physical exam test for that is patients should have no pain with resisting two fingers in flexion, but reproduction of their index pain with just a single finger resisted flexion. And then this letter D is saying that you can, if you push your finger back into this completely flexed position like this, you can feel stretching kind of deep within the palm of your hand. And that is a stretching exercise for your lumbrical. I certainly think that may be helpful for sort of loosening up rock climbers' hands, but I don't think that would necessarily prevent this injury if you were doing a single finger pocket hold. So there was one interesting article I saw online from a gentleman who was getting his doctorate in physical therapy, and he had a good suggestion here. He was trying to see if you could minimize the risk to the injury of your lumbricals while still doing a single finger pocket hold. And he found out that yes, you can, if you try this image on the left, where you're keeping your proximal phalanx straight and just bending your fingers at the proximal interphalangeal joint. That prevents that altered directionality of the bipennate lumbrical. That being said, most rock climbers don't do that because you do lose some flexion strength doing that. So flexing all of your fingers does give you a stronger single finger hold, but that's something that you could consider discussing with your rock climber friends if they were interested in ways to potentially reduce risk of that injury. Going back into some of the carpal bones here, the interesting player here is the hook of the hamate. I'm certainly more familiar with this from a racket sport injury. From the sports medicine side of things, the typical injury this will come from is a batter swings and a miss and gets pain on the hypothenar eminence, or a golfer digs his golf club into the ground and again, pain over the hypothenar eminence from a direct trauma to the hook of the hamate. But this is where we're coming back to this undercling position where you're pulling up with your flexor tendons against an ulnarly deviated wrist. This letter A, the blue line is demonstrating your flexor tendons. The red asterisks is the hook of the hamate, and you can cause an acute or a stress fracture through the hook of the hamate with repetitive undercling hand positioning. Letter B is showing you how to try and provocate pain there. The thumb is showing you tenderness over the hook of the hamate. And if you fully ulnarly deviate someone's hand and have them do resisted fourth and fifth finger flexion, you should reproduce pain. This is an interesting little fun picture to know about in letter C. This is called a carpal tunnel view of the wrist. It's obtained by having someone completely extend their wrist and you shoot the beam down through their carpal tunnel. And that'll show you the hook of the hamate on X-ray. Certainly, this is not definitive for ruling in and out a hook of the hamate fracture. If you've got a high clinical suspicion, CT scan is much better for getting that. If any of you guys out there are going to go into sports medicine, though, be warned. I thought this was the to know for your sports medicine boards, and I had this one on my boards of a hook of the hamate fracture, but they didn't give carpal tunnel view as your optional view. So a supinated oblique view is another way to pick that up if you're going to take your sports boards in a couple of years. One more interesting thing to talk about that I decided to put in here, because I think a lot of people don't know about it, and it's one of those things you'll never diagnose it if you're not thinking about it, is intersection syndrome. This is looking at the distal radius and ulna right about the level of the radiocarpal joint at the distal wrist. There are 6 dorsal compartments in the wrist. We're all pretty familiar with the first dorsal compartment that can get tenosynovitis in it that leads to De Quervain's tenosynovitis. That certainly can happen in rock climbers. But a similarly related one that I think could confuse a lot of us is this entity called intersection syndrome. And this is a problem with the first and second dorsal compartments. It's another anatomy problem. I don't know if you guys can see my mouse on here, but it's a similar anatomy problem like the urethra traveling through the prostate. I don't know who designed that. I don't know who designed that the first dorsal compartment here was going to travel over top of the second dorsal compartment. So right at this level where the first dorsal compartment goes across the second dorsal compartment, you can get a friction tenosynovitis at this location. You can also get a more distal intersection syndrome where the third dorsal compartment crosses over the second dorsal compartment. And the way to differentiate this from De Quervain's is basically the location of their symptoms. De Quervain should be more over that anatomic snuff box and along the radial side of the wrist, and the radial styloid specifically. Intersection syndrome seems to happen a little bit more dorsally and a little more proximally, just behind the DRUJ. This one also is interesting. If you get the board presentation of it, you'll now know because it's so weird. I had one of our fellow faculty attendings when I was a resident say he was out rock climbing and he's getting some pain in his wrist. And the weird thing was his wrist sounded like a door creaking when he flexed and extended his wrist. And it truly did. You could hear this creaking on the back of the wrist. It sounds like shutting and closing a creaky, rusty door. And that's a great example of a florid intersection syndrome and that tenosynovitis where those two compartments cross each other. So I know that's a lot of information, and most people don't tend to remember more than like 10% of the things that are given in any one particular lecture. So this would be one thing I could leave you with that's basically helpful for any overhead throwing athlete. So I basically equate rock climbers as overhead throwing type athletes, but if you get tennis players, basketball players, baseball players, pickleball is big these days, all of these patients would benefit from what's called the Throwers 10 program. It's initially generated for rehab in the major league overhead baseball community. But this would be a great PDF that you can just Google Throwers 10 PDF, and there's a million flavors of it, and give it to your patients to work on rehabilitation of the rotator cuff. It focuses on deltoid, both anterior, middle, and posterior deltoid. It works on trapezius and the rhomboids and pulling your shoulder blades together. It does a little bit of stuff for the elbow with resisted wrist extension and flexion, as well as pronation and supination. So it's kind of this good overall, man, I'm not sure what's going on, but it seems to be in your wrist, hand, elbow, and you do something that involves a lot of overhand activities. Why don't you give this a shot for all those people who don't have time or aren't interested in going to therapy. Let's see, got done a little bit early there, at least with the slides. Let me pull open the chat here and see if there's anything to talk about, and then certainly able to take some questions, and we can feel free to go off topic.
I think that Dr. Kern just had a few comments while you were chatting.
Sure, yeah.
A great presentation. Other questions, I can unmute ISU if it would be helpful. Actually, maybe I can't unmute you. But if anybody has a question there, unmute and put it in the chat, or others, comments or questions written in the chat, or unmute.
Hey, Dr. Sugden, great presentation. Don't, with the fully pronated hand in that sort of rock climber position, isn't the brachioradialis helping flex the elbow as well?
Oh, absolutely. Yep, that would be, and that could certainly give you pain more on the ulnar side of the elbow as well. Yep, great call.
Any other questions or comments? Some people have been asking about how to get the CME, and I just sent that to one of our attendees today, but I'm going to put that in the chat again for those of you who are needing the CME.
I guess thinking of other things I was going to touch on and then breezed over for other common family practice issues, people who have medial and lateral epicondylitis and they're not getting relief from the counterforce brace. Don't forget, you can always try wrist bracing, same as you would for carpal tunnel syndrome. Some people tolerate that brace better with whatever their work obligations are. And that would also limit flexion and extension that can offload that pain at the elbow, despite the brace being pretty distal from that. Something else I was going to touch on with the labral tears and injuries. I think a conceptual reason that people get pain with labral tears that resolves with therapy, even though that's not fixing your labral tear. The labrum is a pretty avascular structure, just like the meniscus, so they don't tend to heal on their own. Part of what the labrum does is there's a negative suction inside all of our joints, certainly within the glenohumeral joint. And the glenoid is a pretty shallow socket, and that allows for this incredible range of motion in the shoulder, but you need to then use the rotator cuff, and the negative suction is so much more important for maintaining stability of that joint. If you get a labral tear, you lose that negative suction, which is actually a big contributing factor to stability in the glenohumeral joint. And that makes the rotator cuff work overtime to compensate for that. And it tends to be that weakening leading to impingement, and patients will come see you with findings consistent with rotator cuff impingement, and you get your MRI and there's your labral tear. That's what the problem is. You need to treat the rotator cuff impingement, and if their symptoms go away, don't go chasing down that labral tear. They don't need surgery. They just need to do rehab every once in a while to keep their rotator cuff strong.
Great. Any other questions or comments before we close up? Well, excellent presentation, really interesting. I have a 20-year-old who is a rock climber and has definitely had some of these injuries. So I will be having him watch this video because as a mom, I will just say it's always like, what did you do? They're confusing. The injuries can be like perplexing for a climber. So this was really, even to a lay person like me. For those of you who need CME credit for today's presentation, I've dropped the link into the chat. Please email me or send me, or just fill out that Google form. Dr. Sugden, if you could provide the PDF of this presentation, just email it to me. I will make sure that when I send out the CME certificates, that's included. And then I just put this in the chat, but we have started a new CME library on the page of idahofamilyphysicians.org. If you click through, a lot of our CME that we've recorded is there, and this will be there in the next month or so. It is not available for continuing medical education. It's not an enduring credit, but as a resource, if people want to look at previous CMEs as well as this one, that's where those will live. Dr. Sugden, is there anything else you'd like to say before we close out?
No, that's great. I really appreciate everyone's time. Thanks for attending.
Yeah, and we hope to see you all again on December 11th for our next grand rounds. Have a great day. Thanks so much.